NHA Phlebotomy Certification Exam. Question 1. During venipuncture, a patient suddenly reports a cold burning sensation spreading from the puncture site. There is no visible swelling yet. What is the most likely cause? Hematoma formation, nerve irritation, arterial puncture, allergic reaction to antiseptic. A cold or burning sensation radiating from the puncture site is most consistent with nerve irritation. Unlike hematomas, nerve-related discomfort often occurs before visible swelling appears. Immediate needle removal is required to prevent nerve damage. Permanent nerve injury can result if the needle remains in contact with the nerve. Question 2. Which vein condition most increases the risk of vein collapse during vacuum tube collection? Deeply located vein, elastic rolling vein, sclerosed vein, fragile vein in elderly patients. Elderly patients often have fragile veins with thin walls that collapse under vacuum pressure from evacuated tubes. Using a butterfly needle with a syringe allows manual control of suction, reducing pressure on fragile veins. Alternative techniques such as using a smaller tube or releasing the tourniquet early can also help prevent collapse. Question 3. A phlebotomist must redraw a specimen because of clotting in an anticoagulated tube. Which action best prevents recurrence? Increasing tourniquet time, shaking the tube immediately, ensuring complete tube inversion, using a larger needle. Clotting in anticoagulated tubes usually results from inadequate mixing. Proper inversion, 8 to 10 times, immediately after collection ensures anticoagulant distribution and prevents clot formation. Insufficient mixing allows blood to clot even in tubes containing EDTA, heparin, or citrate, rendering the specimen unusable for hematology or coagulation testing. Question 4. Which situation creates the highest risk for hemoconcentration during venipuncture? Extended tourniquet application, drawing from the hand, using a butterfly needle, collecting multiple tubes. Prolonged tourniquet application over 1 minute causes plasma to leak into surrounding tissues, concentrating blood components and altering test results. Hemoconcentration falsely elevates hemoglobin, hematocrit, potassium, and protein levels. The tourniquet should be released as soon as blood flow is established or within 60 seconds, whichever comes first. Question 5. Why should the tourniquet be released before withdrawing the needle? To reduce infection risk, to prevent vein collapse, to decrease hematoma formation, to improve specimen flow. Releasing the tourniquet before needle removal reduces venous pressure, minimizing blood leakage into surrounding tissue and lowering hematoma risk. If the tourniquet remains on during needle withdrawal, continued venous pressure forces blood out of the puncture site before clotting can occur, leading to hematoma formation and patient discomfort. Question 6. Which patient condition requires the most cautious venipuncture technique? Hypertension, long-term steroid use, diabetes mellitus, mild anemia. Long-term steroid use thins the skin and weakens blood vessels, increasing the risk of tearing, bruising, and prolonged bleeding. These patients may have fragile veins that collapse easily and skin that tears with minimal trauma. Use smaller gauge needles, apply gentle tourniquet pressure, and extend pressure time after needle removal. Question 7. What is the primary risk of probing for a vein after a missed attempt? Increased infection risk, vein spasm, nerve or tissue damage, hemolysis. Probing increases the chance of damaging nerves and surrounding tissues. If the vein is missed, the needle should be withdrawn and a new site selected. Probing, redirecting the needle without withdrawing, can cause significant tissue trauma, nerve injury, and increased patient discomfort. Most facilities limit probing to 1 or 2 gentle redirections before withdrawing completely. Question 8. Which observation suggests an accidental arterial puncture? Slow blood flow and dark color. Bright red blood with pulsation. Immediate hematoma formation. Tingling sensation. Arterial blood is bright red and may flow rapidly or pulse due to higher pressure. Venous blood is darker and flows steadily. Accidental arterial puncture requires immediate needle removal and firm pressure for 5 to 10 minutes to prevent hematoma formation. Arterial punctures carry higher bleeding risk and may require medical evaluation. Question 9. Which factor most affects patient comfort during venipuncture? Needle gauge. Tourniquet material. Angle of insertion. Skin cleansing agent. Proper insertion angle, 15 to 30 degrees, minimizes tissue trauma and reduces pain during venipuncture. Too shallow an angle may not enter the vein, requiring additional attempts. Too steep an angle increases the risk of penetrating the posterior vein wall, causing hematoma. The bevel should face upward for smoother skin penetration and better control. Question 10. A patient has a history of syncope during blood draws. What is the best preventative measure? Have the patient lie down. Draw blood quickly. Use a smaller needle. Avoid tourniquet use. Positioning the patient supine, lying down, reduces the risk of fainting by maintaining cerebral blood flow. If syncope occurs, the patient is already in a safe position, preventing injury from falling. Additional measures include using distraction techniques, avoiding prolonged fasting, and having ammonia inhalants available in case of fainting. Question 11. Which site should be avoided due to increased risk of inaccurate results? Arm with hematoma. Basilic vein. Median cubital vein. Cephalic vein. Drawing above or near a hematoma can dilute the specimen with tissue fluids, altering test accuracy. The hematoma contains leaked blood and interstitial fluid that can contaminate the sample. Additionally, venipuncture near a hematoma is more painful and may cause further bruising. Select a site at least 1 to 2 inches away from any visible hematoma. Question 12. What is the most appropriate needle gauge for routine adult venipuncture? 16 to 18 gauge. 19 to 20 gauge. 21 to 22 gauge. 23 to 25 gauge. A 21 to 22 gauge needle balances adequate blood flow with minimal vein trauma, reducing hemolysis risk. Larger needles, 16 to 18 gauge, are used for blood donation. Smaller needles, 23 to 25 gauge, increase hemolysis risk due to increased resistance and are typically used for small or fragile veins with butterfly needle sets. Needle size selection should consider vein condition and required blood volume. Question 13. Why should the bevel be facing upward during needle insertion? To reduce bleeding. To ease skin penetration. To prevent clotting. To increase vacuum pressure. The bevel up position allows smoother penetration through skin and vein walls, minimizing tissue damage. The bevel's slanted edge creates a smaller puncture site and reduces patient discomfort. This orientation also provides better control during needle advancement and helps ensure complete entry of the bevel into the vein lumen for adequate blood flow. Question 14. Which step is most critical in preventing needle stick injuries? Using smaller needles. Activating safety devices immediately. Wearing double gloves. Disposing needles later. Immediate activation of safety devices after needle withdrawal is the most effective method to prevent accidental needle sticks. OSHA regulations require safety-engineered sharps devices and immediate activation after use. Never recap needles, dispose directly into sharps containers. Safety devices should be activated using one-handed technique or according to manufacturer instructions. Question 15. What should be done if blood begins to leak around the needle during collection? Increase vacuum. Remove the needle immediately. Tighten the tourniquet. Adjust needle position slightly. Minor needle adjustment can reseat the bevel properly within the vein and stop leakage. Blood leakage often occurs when the bevel is only partially inserted or is against the vein wall. If gentle adjustment does not resolve the leakage within 1 or 2 attempts, withdraw the needle, apply pressure, and select a new site for venipuncture. Question 16. Which complication is most common in patients with fragile veins? Infection, hematoma, nerve damage, thrombosis. Fragile veins rupture easily, leading to blood leakage and hematoma formation. Elderly patients, those on steroids, and individuals with chronic illness are most susceptible. Using smaller gauge needles, applying gentle tourniquet pressure, and using butterfly needles can help prevent vein rupture. Extended pressure, 5 to 10 minutes, after needle withdrawal is essential to prevent hematoma formation. Question 17. Why is excessive anchoring pressure discouraged? It causes infection. It collapses veins. It increases patient pain. It affects blood chemistry. Excessive anchoring stretches the skin unnecessarily, increasing discomfort without improving vein stability. Proper anchoring uses gentle traction to stabilize the vein without causing pain. The thumb should pull the skin taut about 1 to 2 inches below the puncture site using moderate pressure. Excessive pressure can also compress the vein, making access more difficult. Question 18. Which factor most increases the risk of vein rolling? Poor anchoring, large needle gauge, short tourniquet time, shallow insertion angle. Inadequate anchoring allows mobile veins to move away from the needle during insertion. Veins that roll require proper stabilization by pulling the skin taut below the puncture site. Using the thumb of the non-dominant hand to anchor the vein prevents lateral movement and improves first stick success rates, especially in elderly patients with loose skin. Question 19. When is it acceptable to attempt venipuncture more than twice? Never. With patient consent. Only in emergency situations. When a supervisor approves. Most policies limit attempts to 2 per phlebotomist. Additional attempts require supervisor authorization to protect patient safety and comfort. After 2 unsuccessful attempts by 1 phlebotomist, another phlebotomist should attempt the draw. Excessive attempts increase patient anxiety, hematoma risk, and potential for complications such as nerve injury or vein damage. Question 20. What is the main reason for avoiding venipuncture in edematous limbs? Increased pain. Difficulty locating veins. Dilution of specimen. Risk of infection. Excess interstitial fluid dilutes blood samples, leading to inaccurate laboratory results. Edema increases the distance between the skin surface and veins, making palpation difficult. Additionally, fluid accumulation can alter electrolyte and protein concentrations. Select an alternative site without edema, or consult the provider if no suitable site is available.